right, so welcome everybody. I think we have all the major players in the room here who wanted to put this together anyway. So we're going to do a collaborative run review. This is where you picked out 3 case reviews, and then for people who are going to do this for CEUs later, we're going to have this set up as an online training that you can do, and then you'll receive the classic quiz and survey so that you can complete those, and then we'll issue the CEU certificates from there. They are in the, I have the RN stuff on them. We can discuss as far as long as we're honoring all the obligations we are to issue RN CEUs. But I know the certificate is appropriate as long as we're following the rules about notifying people and all that stuff. So. All right, so kind of this was a combined effort by St. Louis Children's, and in full disclosure, it was Sabina Sagner's idea, and she's here, so thank you, Sabina. All right, and then we kind of came up with the idea from both children's hospitals of this idea of doing some run reviews, talking about pediatric transport, making sure that our patients are getting to appropriate facilities, and also just kind of looking at some cool calls, patient outcomes, and to kind of talk about what we can do, what EMS is doing well, and what we can do to improve in their transport decision making. So there is the purpose. We did pick out kind of for the format, we're going to do 1 medical review, 1 trauma review, and 1 STARS call review. And then also just to, we want to acknowledge the challenges that exist in pre-hospital transport decision making. So this is a big thing from both pediatric hospitals that we are really wanting to emphasize as we move on forward here, and that is right place in the first place. And we'll discuss all the different factors that affect, how patients end up in different places, different hospitals, and, but we really want to emphasize when you have a patient, the ultimate goal is to get them to definitive care in an appropriate facility that can handle their emergency. And depending on the acuity of their emergency, that might be a tertiary care, a community hospital. But when we start looking at our sicker and more complex patients, we really want to remember that the ultimate goal is to get them to the facility that can handle their emergency. So factors that affect EMS decision making. So obviously the patient plays a huge role, their mechanism of injury, the nature of their illness, what's going on, how sick they actually are. Their stability also plays into a factor of whether, even if they are sick, how far you think you can make it with them before you need to seek higher levels of care. And then we want to acknowledge different transport considerations. Obviously, these trainings, we're talking to a wide swath of EMS providers, and there's a huge difference between whether you're 2.5 or 3 hours from here versus you're 5 minutes down the road sitting at Engine House 32 in St. Louis City. So we kind of want to acknowledge that all these play a role, your transport times, if you're rural, the availability of flight. Sometimes there's a cloud in the sky, sometimes there's not. And then also some of our districts very much have to deal with the reality that they only have 1 to 2 ambulances covering an entire county. And there is, some discussion to be had as far as, if that ambulance leaves for a 4-hour transport, they just deprived an entire county of 911 support. And we can kind of take that discussion a little bit further. There's a weighing of, you're doing not as well by the patient you have with you for the future opportunity of treating another potential patient in your district. And there are certainly some trade-offs there. And then also things that factor in for EMS, facility determination, first of all, knowing what's going on with our patient and what services they're likely to need down the road, and then kind of anticipating their clinical course, and then always weighing off, that trade-off, if you do choose to go to a closer facility and then that patient has to be transferred, or I'm just going to use the phrase retransported because in all honesty, that patient already had transport. We stopped it and now they're having to be transported again. And while that sometimes can be appropriate, we do need to acknowledge that if that first transport was capable of doing the right thing by that patient, we have introduced an unnecessary retransport. So the first case we're going to look at is a trauma case review by Josh. And so without further ado.
I think it's good to make sure we know who we have in the room that's here, that's available to kind of chime in on this. So we have Dr. Steve Laffey. So he's the our pediatric emergency medicine professor and also our EMS guru, and provides lots of pediatric direction. We've got some nurse coordinators that do a lot of educating. We have an EMS coordinator for an entire system, and we have our STARS team. So we've got a diverse group of folks that are just ready to provide wonderful expertise and hopefully a good discussion as well. So I really like this case because I think it shows the power of knowing your area, knowing your resources, and doing the right thing for your patient. So this patient is a 17-year-old female, and both of the children's hospitals in St. Louis will take patients up to 18 years of age, which is not really the norm across the United States. Most other pediatric trauma centers cut off at 15. St. Louis Children's and Glennon will both see up to 18 and sometimes up to 21 if they come in, but definitely up to 18 for sure. So we get a ton of ATV accidents in this area of the world, and they really are quite devastating injuries. So we had a child, 17-year-old, on a Polaris ATV on a gravel road. They, of course, did not make a curve and hit a concrete culvert and then was ejected from the vehicle. And there were no safety devices being worn. So the timeline for this, we had the accident happen about 3 o'clock. The ground EMS arrived about 15 minutes after the accident actually happened. Decent vital signs. We can see a little bit tachycardic, especially for a 17-year-old. They were unable to get an SpO2 on the patient, and they had already noted that her Glasgow Coma score was 10. So prior to them arriving to the scene, they actually realized this sounded like a very injured patient. They knew where they were headed, and so they contacted their dispatch center and had a closest helicopter dispatched. So within 10 minutes or so of the ground crew arriving, we had the helicopter EMS that was on the scene, which is fantastic. Their first assessment on that patient showed that her vital signs remained unchanged, but her GCS was improving a little bit, so she was up to a 13. They did note the scoring there, which is really great documentation if we can get that, especially for our trauma patients, for our neurosurgery team. Because if you can tell us where they lose points at, that really does help drive their care and allows them to make some good decisions. They did note that her pupils were equal, round, and reactive, and they were 2 millimeters and bilateral at that time, which is wonderful. They were only on the scene for less than 15 minutes, so pretty quick on scene and then liftoff, and then they arrived to Cardinal Glennon at 16:37. So what happened during all that time? So they did normal C-spine precautions. They placed her on high flow too, and they provided IV access and gave a total of 1.5 liters of fluid bolus. So we can see that her pressure got a little bit soft for a while, so down to 90s over 40s. They were able to give that fluid bolus and raise her blood pressure and decrease her tachycardia. So it became a little bit more stable. The reason why I love this case is I get a lot of folks that will tell me, you know, it's hard to get to a pediatric trauma center. You know, you guys are 30, 40 minutes away and it just takes a long time. Take a look at the timeline on this. So this patient was 125 miles away from us, and from 92 minutes from the time that 911 was called, she was being cared for in our trauma center. So it shows that there are some options there. You just have to think of them a little bit more creatively. Be ready to use those resources that are within your community and get that patient to the place that's going to fix them. Because this patient lived in an area without any trauma centers whatsoever, so it definitely would have been a double transport, as Nick talked about just a moment ago. So once she arrived to our trauma center, of course, we activated a full trauma activation on her. She got the normal trauma films, and then we took her over to CT, which just is about 50 feet or so away from the emergency room doors. Went ahead and got a CT brain. The CT is a C-spine. We knew that she had a lot of facial injuries, and then we also needed to take a look at her chest as well. And then they also had concern we're going to see some fractures in her lower extremities. So they did a CT angio, just making sure that we had good blood flow. We did keep that same GCS once she arrived to us. And you can actually see a snapshot out of the trauma registry. This is a really important thing that I think just demystifying with EMS and outside hospitals. Once those patients arrive to a trauma center, literally we pull about 500 data elements from EMS charts and outside hospital documentation in order to really paint a picture of what happened with that patient from the moment of their injury until discharge. And so we grab all that info, dump it into a giant database, and that helps us just provide for optimal outcomes for not only this child, but the next child that comes through our doors. Once she was taken and stabilized in the emergency room, she actually didn't need to go directly to the OR, which is a pretty high percentage of pediatric patients. Rarely do they get rushed off directly to the operating room. Most of them can actually take a stop off in the ICU, usually for several hours and sometimes overnight before they actually need anything done. But sometimes they will go directly to the operating room. So taking a look at this young lady's injuries, and the main thing that was causing her Glasgow Coma score to be affected was that she had that intraventricular hemorrhage and subarachnoid hemorrhage. And then you can actually just see that we've kind of lost the normal look of a brain there, right? So we have that diffuse axonal injury globally across all of her brain structures. Nice CT cuts there where we can actually see she had bilateral mandible fractures, and we're going to see where that actually played a quite significant part in her follow-up and care later on in the coming days. So pulmonary contusions bilaterally. So she was, like I said, unrestrained from that vehicle and or unrestrained from that ATV and took that direct hit into that culvert. And so don't really see many rib fractures, but definitely bilateral pulmonary contusions. Ended up with a solid organ injury, so a grade 4 liver laceration. So the highest grade you can get is a grade 5, so quite severe, but it's going to be non-operative. We actually take care of most of our solid organs without actually going to the operating room, which is fantastic. We'll talk more about that in a moment as well. Noted a hematoma to her adrenal gland. She also had a grade 3 renal laceration. And then she had some C-spine fractures as well. So she had a burst fracture of her T-spine, T4, and that's where I have it actually highlighted there. We can see that it was actually completely burst. And then she had fractures in 3, 5, and 8, lots of compression fractures, and then broke off several of the transverse processes that you can see over on the right-hand side. Hopefully you're able to see my mouse in the presentation. So this is one of the most indicative injuries of a high speed, high mechanism injury, is actually fracturing your scapula. It's really, really hard to break your scapula. And if you successfully do that, you have had a high rate of energy transfer to your body. Right tib fib fracture. And then also, I didn't have images on these, but just wanted to show those off as well. So she had a C1 fracture as well. So it fractured that the arch there. Luckily, it did not involve her C-spine. She did have a flail segment on that right side, so ribs 1 through 4. And then she had a brachioplexus injury. So those are going to lead to decreased function either for a short term or sometimes long term. And we'll see again how she went through rehab too. So whenever she got to the ED, we went ahead and intubated her, took her up to the ICU. And in the ICU, actually, they did the invasive neuro monitoring. So there's no reason to go to the OR if we're simply going to put a pressure monitor in. So we're able to do those at the bedside in the ICU. She was taken within a day or so and had her tibia fixed by nailing it. She also had a spinal fusion done. And then one of the biggest injuries that she had is that she had those bilateral mandible fractures. And so she needed that ORIF fixation in order to stabilize those. And then if you have all of those facial fractures, you're probably not going to be a really incredibly safe patient to ventilate on your own. So she actually received a tracheostomy simply because of her facial fractures, and then needed a G-tube, again, because 1, you're not protecting your airway because of the fractures, and then 2, you're not able to chew, so, or masticate, as we like to say. So, thank you, Dr. Laffey. I appreciate you liking my medical terminology. I will try to throw in stridulus at some point because that is his favorite word. So she got a trach and a G-tube simply because of her facial injuries, nothing to do with the head injury. She actually hung around here till day 40, and then we were able to discharge her back home to her area. We call it repatriation because it's really hard for patients to drive, or their families to drive 2 hours up here every day. Yes, both hospitals have access to the Ronald McDonald House. We try to really make it easy stay for them, but you really recover best whenever you're back with your family and your friends. And so we look for getting them back home and repatriating them there. This wasn't too bad because she was only a couple hours away, but we've had to repatriate kids to Georgia and back to the Pacific Northwest who are traveling through here and got in accidents. Those get a little bit complicated, but our social work teams do really good as far as finding those connections and getting them back home. We talked about organ treatment, and we said that a lot of those solid organs are non-operative. And I just wanted to share, this is our solid organ injury protocol. So in the old days, we used to take a lot of these kids to the OR, and now we're finding that we just don't have to do that quite as often. So we're able to take a look at them, grade them, and this just kind of gives us a layout of how long they need to stay in the ICU, do they need to be NPO, when can they get up, and what sort of labs do we do. We follow every patient that meets this criteria, and we make sure that it follows it. And if there's any outliers, we definitely document that. We're working on that as part of a research protocol to make sure we're doing the right thing for our patients. Because one of the things, if you take out your spleen, you become a lifetime of being more affected by immunocompromised instantly. So anytime we can preserve it is huge. Yeah, it's amazing. It sounds horrible. You're like, oh my gosh, this kid has a horribly injured solid organ, and it's okay. You let them rest. You watch them for a while. You provide them with great support. You make sure that nothing is going on with that. And one of the big things you may think, well, if the hospital's not going to do anything and they're literally just going to watch them, is it okay to take them to a non-trauma center? Well, one of the ways you're able to do a solid organ protocol like that is you have to have 24-hour available surgery to, if something goes wrong and all of a sudden this kid becomes unstable, then you have to be able to open them up immediately. So they can't do the solid organ protocol at an outside hospital that doesn't have pediatric surgery. So follow up on this case. So she was able to have her trach taken out and decannulated after 3 months. And then at 6 months, she actually came back in trauma clinic doing really, really well. So her head injury had really went away. She no longer needed that G-tube because everything had fixed itself. And she did not have this right arm deficit because of the head injury. She had it because of that brachial plexus injury. So she was doing wonderful. She was back in school and had a really successful outcome. And I think one of the reasons why is because we had that early notification to EMS, who then notified the closest helicopter service. Our helicopter service providers, regardless of which service is out there, all do a really wonderful job. And so having them there quickly, they're able to support that kid, and then really to go 127 miles in 92 minutes from the time of injury, that was amazing. So definitely a case that stood out here.
I'm going to proceed with the STARS case review. All right, and so we've gone over this case a little bit here recently, but especially for the purposes of this presentation, it does fit very nicely. So this was a STARS kid from Illinois. They live in Region 4. There are STARS 70 there. And they experienced an emergency. You can see there in the evening time. The mom, she's one of our very capable special needs mothers, and she was sitting there in the house trying to figure out if she could take care of all of this herself. And she had a vomiting kid who wasn't breathing well, and then she was trying to decide whether she could drive down here to Cardinal Glennon. Unfortunately, she talked to her husband on the phone, and he kind of pointed out that that really wasn't safe or feasible. So she activated 911, and they dispatch it as a STARS call. You can see the dispatch notes there for dyspnea, shortness of breath. Oops, gone too far. And here are your call times for this case. So you can see really good response time. So call received, dispatched, and then they were en route 3 minutes later and arrived at the scene 3 minutes after that. 18 minutes on scene, and as we see the complexity of this patient, that's really a pretty reasonable number. And then down in the narrative text, you can kind of get the beginnings of the call. So the crew knew they were going to a 17-month-old female with difficulty breathing, a known trach patient. And then they also note her notes about STARS 70, that she has congenital central hypoventilation syndrome. And then they noted some of the side effects of that with hypercarbia and hypoxia being two of the main ones. It was also very fortunate for this crew. So they actually had trained with this specific kid about 1 year before this call happened. So they were familiar going into the call. And here is the STARS form for that young lady. So you can see her history. She is vent dependent anytime she's asleep. So at night and for naps or anytime you're worried she might go to sleep, such as a car ride. But her baseline, she is normally interactive and alert. She is able to speak some. She does interact with her caregivers. So you can kind of see some of that. And then here's some of her anticipated emergencies. A lot of our classic emergency trach care training is here, as far as assessing your trach, making sure it's patent, and then also being willing to change it out if you think you have a plug or a bad trach. Her medical equipment, she does have the Trilogy home ventilator. You can see the details about her trach there, a 3.5 cuffed. And then she's actually one of the most complex kids we have in that the pressure in her cuff actually changes depending on time of day. So I got some home meds and allergic to lactulose. So for the crew, as they ran the call, you can see their notes on their initial assessment. So they did find her to be pale and cool. They noted abnormal lung sounds, which they call bronchi. But she did have, as far as they called airway patent, skin condition normal, and general circulation normal. And then her neurostatus was normal upon EMS arrival. So here are your vital signs for the case. So initially, blood pressure, there's kind of a drop there. Initial blood pressure is 100/76, and they note the later sets were 71 and 54. I don't know that that was so much an issue, but the one thing we do note on this call, and we can kind of discuss more at the end, but just the vital sign times are maybe a little too spread out for my liking, especially if you get that big of a change in one of your vital signs. You probably want to get back after that a little sooner and see, was that a legitimate change or just, a bad reading by the monitor or something like that. So, other than that, though, they kind of know, you can see some of your SpO2 readings here are a little low, but as we'll see, they kind of know that they had trouble getting good pleth throughout the call. And then the one conspicuously absent vital sign here is that end tidal is not registered anywhere. And we'll discuss that just a little bit more. So the crew does have their treatments laid out here. So they did put the patient back on her ventilator. With the help of mom, we'll kind of talk more in the notes, but mom did end up bagging this patient a little bit prior to EMS arrival. And then you can see there where they said they put the pulse ox on, but they attempted it 10 times and really had trouble getting good readings with that. And then cardiac monitor was sinus tach. So the crew did find, or the story was, so mom was giving the kiddo a bath. She'd been sick all day, vomiting, diarrhea. So mom was trying to get her cleaned up. And the kids started to have some distress in the middle of the bath. Of course, the hardest point for mom to do anything about it. So that's part of where she ended up calling 911. And then she kind of thought that the kid might have aspirated after vomiting in the tub. There was some fluid bubbling around her stoma, and the kid became cyanotic. The respiratory rate you can see there is normal for her. And then they noted bronchi, though, and that's part of where they thought maybe some aspiration. They did note that the abdomen was distended and firm. And then mom, like I said, we know that mom did bag for a little bit prior to their arrival. And then with EMS there, they placed her back on the vent. They attempted suctioning without success. And then they kind of noted that the kid was really pretty cold and they were having trouble getting a good SpO2 reading. Other than that, just monitored the kid throughout, and they kind of didn't know the kid maybe looked pinker for a while, but they did know she also became cyanotic again during transport. As far as when this crew was picking their destination, mom actually left it up to the crew, which is somewhat notable because, like I said, this is one of our super on top of it moms, and she would want to make it down here. So I think it is a measure of how significant the event was to her. That she kind of told the crew, if you don't feel comfortable, we can go to a closer facility. But the crew did know the kid. They kind of felt like they had the situation under control, and with mom's help, opted to come down to Cardinal Glennon. As you can see, kind of the distances, it would have been 8.4 miles to the closest hospital, and then it was 29.3 here. But their transport time, I think if you work it out, was something like 18, their transport time was really only like close to 30 minutes, and it would have been just 14 minutes to go to the closest facility. So for the cost of 15 to 16 minutes, they did get the kid to definitive care. And then we can kind of see some of the lab values there for the kid when they got here. So the biggest thing here, as far as she was extremely alkalotic, and her CO2 was very low, which seems a little counterintuitive when we talk about a kid whose primary emergency, we're worried about hypercarbia. But these kids with congenital hypoventilation syndrome, the big problem is that, they aren't fully their autonomic nervous system isn't working well, and they are not regulating their autonomic functions well, and so they can actually kind of go both. She has a problem where she hyperventilates and then drops her CO2 just because she has such poor control. So her ultimate clinical course, she did end up staying at our facility for quite some time to get her alkalosis under control. Kind of what they think kicked it all off was the GI problems that she was having, and she ended up with an infection. And so with the extra distension, it affected her ability to ventilate well, and that's where she started to get into some distress. There were some additional factors. She had recently had a lot of her vent settings changed, and there's some compounding factors where that may have also affected her physiologic status. The overall, we feel like this call went pretty well. The crew did well. They had a quick response. It really helps that they did know the patient prior to this emergency. They did a good job of including the mother in the treatment process. As far as they did try to kind of mitigate the factors for SpO2, and then they cleared their life threats and then made the decision to go to definitive care. There's always some room for improvement, some things I thought could have been documented a little bit better, and that's just anytime you're running a trach patient, we really want to see, a clear commentary that you assess that trach, that you visualize that the trach was in the appropriate place. It was in the stoma. They had not decannulated themselves. And then also, what signs did you have that air was patently moving in and out of that trach? Did you have, good chest movement, good lung sounds, and so on and so forth. Other things as far as just some simple things, but it was never really documented how the patient was moved or secured to the stretcher, and we're really looking at that more and more in our pediatric patients, making sure that they're properly secured. We put all these emphasis on the parents and the families out there in the community and make sure they're securing the kids right. And we just want to make sure that EMS is also doing a good job while we transport other people's kids in the backs of the ambulances. One thing, something that she's particularly prone to with her syndrome, and then just kids in general, is just to make sure the crew noted that they thought she was cold, and she'd just come out of a bathtub, but there was really no documentation of any steps to warm the patient. So maybe just whether that's passive with a blanket or whether you reach heat pack levels, but that could also kind of explain your SpO2 levels being difficult to register. And then vital signs just more frequently, and this is, I think, becoming more and more thing as we emphasize, critical patients, 5 minutes, non-critical every 15. And, I would argue that this kid is pretty high risk. So you probably, especially if you have any vital sign changes they did, you really want to make sure you're getting back after them more frequently. End-tidal CO2 is big on this kid. And the only caveat I'll give them that we don't know is she was on her ventilator, and I don't know if mom also had a CO2 monitoring device, which I know they have available. So it's possible that this was actually monitored in the call, but it wasn't documented, and that would really be a solid thing for you to document on this call. Obviously, any kid in distress, blood glucose level, the temperature, because we did say they were cold. And as Dr. Aleffi has previously pointed out, and I don't know if he wants to follow up on, but kind of some indications, that this kid was sick, and there was never an attempt for an IV, and some question of whether some fluids might have really benefited the kid.
So Robert and I are gonna do this together, because this case, this particular call review was set up with the idea that we wanted to talk primarily about right place in the first place, which is extremely important. This call was one of those calls where they had a patient in cardiopulmonary arrest and they had a hospital next door. The choice was clear. So it's not as much about destination choice as it is about the uniqueness of the call and the fact that I thought we just couldn't pass it up. Something I've been saying after reviewing 2016 is provided with me with is that I said we pretty clearly have 3 categories, and those are infant co-sleeping, children with complex medical needs, severe complex medical needs, and trauma. So to have this spontaneous, unexpected arrest was extremely unique. And then the fact that it was a save, those things combined, we just decided that we had to add that to this review. So I'm going to start off a little bit by introducing his history, and I'm going to let Robert take over. So this was a 15-year-old male who was driving. He was followed by our cardiology clinic already for frequent PVCs, or what they'll say is he had a heavy PVC load at baseline. So he has on atenolol, but the thought was that he didn't have any type of prolonged QT syndrome, and that during exercise, when they would stress test him, those would dissipate. So when he was under stress, because this is a kid that was typically in bigeminy, like 40% of his beats were ventricular beats at baseline. But this is a very athletic kid. He's an adult-sized kid, which is going to come into play a little bit later on. And when they would throw this kid on a treadmill, they go away and he would normalize into a normal sinus rhythm. So they honestly, looking at all the notes from prior, did not consider him to be at high risk for this event. So driving had this, per his dad said, staring spells, stiffened almost cedar type activity with incontinence, and 911, thank goodness for them, was right around the corner with the hero sitting next to me.
Just against my narrative off my run sheet, we found the child had, the child had very weak pulse, rhythm breathing, cyanotic. I had no idea this gentleman was 15 years old. I was in their early 20s, something like that.
So you even have an age?
No, because all I could say was, get out of his dying. I kept saying that.
Oh, wow.
And people really run one paramedic and one EMT on an ambulance. And so we don't have a whole lot of ALS coverage with the paramedics everywhere. I always joke around about it being my student loan job on the weekends. So I work for that.
I do the same.
And as far as, history and then allergies all in there. The child was unconsciously cooperative of shallow respiration, cardiac monitors applied. Initial rhythm was really kind of steady with facades, because who sees a kid in facades? The initial rhythm was that on top. Also said it was done on a simulator. And I'm thinking, why would this kid be a facade? I've really seen few facades. I was in the early days when cocaine was popular. Whereas on dialysis patients, it was like attractive people. So I've not seen it on a kid ever. So I was kind of, well, the child ended up arresting. So we treat it as if it was VFib and defibrillated, standard rules. It's called the PEA. In back the ambulance, we had BLS providers and me. We had a BLS provider doing really good ventilatory support and one doing really good compressions. I opted to go with the supraglottic airway just due to logistics. And I'm really worried about like perioinnovation hypoxia, which is a big concern. So I go in, no problem, fix that patient afterwards. There's a lot of concerns about medics innovating people to death for years. And there's a lot of, it's a hot topic right now across the country. So when I had defibrillated, let's see here. I came back and I called it accelerated ventricular rhythm. It's just a bad thing. Had a brief pause with that. Due to the lack of information, a young kid with respiratory rescue failure gave him Narcan without knowing anything on this child. I went for it again, and then we defibrillated that once we checked for CPR. After the third or fourth defibrillation of the child developed immediate ventricular rhythm, PEI, we gave that at that point. Child received 2 doses of it during the cardiac arrest. VFib, and then we went with lidocaine 100 milligrams on the child for the antidyspnea. The versus amiodarone, I took about a minute, but we gave lidocaine, and then the patient, we defibrillate again, had lost, had this initially facial attack, and went into a sinus attack. After that, with good pulse, good blood pressure, and all that. Some of the concerns I had with this is one of the things that we're working on the other WS coordinator is trying to do the paradigm shift with instead of flipping back the truck and driving fast and not doing anything, sitting on scene until you get in some state of stability. And it's really hard to do, especially in rural communities where you have a hospital 2 miles away and families yelling at you. But I have to just sit on scene and work the arrest on scene versus driving fast to the hospital. We had one ALS provider, so obviously the ALS too, but I went with lidocaine versus amiodarone. Once again, logistics. Lidocaine is a pre-filled syringe, and amiodarone has to draw up. And I was in back myself, so it's just logistics. I wish you'd make amiodarone in pre-filled syringe.
Yeah, it comes into play when you're working on time and you're the only ALS provider, correct?
Yeah, and that was like just same with the iGel, it's just logistics. What can get done the most effectively in the quickest manner. So we get the child sent to the hospital with a pulse and all that, and then their staff took over with this child.
Sure, Robert. So looking at that slide, I have never seen anybody in my history of being on the ambulance document that well on rhythm scripts of what in the world was happening, when, and what you did. I don't know what Dr. Lackey has to think about that, but man, does that paint a better picture? Here's a
Well, I'll tell you the reason I do that is because I really suck at using the computer. Okay, it takes me forever to do the drop-down boxes and enter all that stuff. Because he's reading them on a timeline thing, and plus a lot of times it's a transfer thing too. Because at the hospital they did some other things, some additional trips and whatnot. But the hospital initially wanted to take the car back out to the ground, but they had no respiratory spare, no additional nursing spare, and it would just be me with someone driving. And I talked to the doctor, and I didn't feel that safe. I felt we were better off waiting in the hospital for a transport team to come because the weather wouldn't permit the car to be flown, is why we had to think of a helicopter. And then the ground team from here arrived, and they got here about trying to fish run sheet. So I mean, they did a phenomenal job getting there, and then they changed the iGel over to an intake with people in the ER. The doctor initially wanted me. The doctor doesn't work ER tons, and he wanted me to go ahead and intubate the child in the ER. I did discuss it with them because our SAT for 98-99% of the iGel and pilot was good to the ER. So I opted to not fix a good thing. I said, if you want to do it, that's the doctor, but I'd rather not do that myself because one of them work in that hospital. So we agreed to wait for additional people with intubation skills to be there at that time, especially since there was debate over what drugs would be needed for sedation versus this, that, and the other. So we already had agreed on that to leave the iGel in place because it was ventilating so well. And it did well. I'm not normally, I used to be a big fan of superglottics, but I've been really reading the literature, and I'm kind of sold after calling the iGels. They work really, really well.
So wasn't apparently too easy. The comment I was going to make on the strips is that documentation is the only thing they have that he was in torsades, and no one still knows why he was in torsades, but it was questioned quite heavily if that was true until they saw these strips. And these were key, and I've never heard cardiology speak so highly of EMS as they have with you, or be so responsive to me in creating the STARS plan afterwards. I mean, they always communicate with me, but sometimes it takes a little while. But they were quite complimentary, and these strips are all over this kid's chart. I mean, because that's all they had to go on. Otherwise, they would have had no idea. I don't think they would have believed you, honestly, because it says in many places, it says, torsades, question mark, and then you'll see them clarify after seeing the strips that, yeah, you can't really deny that. So not a whole lot going on here that's huge. I just wanted to show some timeline and notes from the ED on arrival from Pinckneyville. Thought it was interesting, and I was going to ask you about weather. I was going to go back and see because they wanted this kid out. You could tell. They called SLU first because he is an adult science kid, and it was SLU that told them that he should probably be sent to a pediatric hospital instead. They called Arch and Aerovac, which I don't have all of those on there, and both declined for weather. So, and then he actually, I guess he came in with dilated pupils. So he was, it looks like, and then became more responsive, pretty darn quickly with them. But his initial 12 leads, I did not post because the quality after the scans, after we've been playing with them, I couldn't get them clear enough to put up on a screen. But his first 12 leads were pretty darn awful looking. They looked like a typical STEMI, and he did have some definite injury patterns at first. So just a little bit clear on what they had there when they arrived. He was hypotensive. They did put him on a Levophed drip, and he did switch over to an Epi drip, I believe, here in the PICU. But our hospital requested the lidocaine bolus and drip, I believe, and then heparin. They really didn't know what was going on with him at that time. A little cold, but it's probably to be expected after you die. So, the stuff our team did, I just wanted to document that when they got there too. They redid labs with their iStat. They transferred all the fluids over the pumps. They documented. They did intubate with fentanyl rock, and like I said, that was 3 attempts by our team. So apparently he wasn't super easy. And then they did chest x-ray to confirm intubation. I was going to ask, is that typical that they would do that while they're there? Okay.
Yeah.
Just curious if they wouldn't rely on, I guess, just placement more than.
Yeah.
Exactly. Placement within, but where it sits above the cardiac. And then, I had to take the time to put him over to the transport ventilator. So not a whole lot done. Well, it depends on how you look at it. It does take some time. Obviously, there was no question on this transport decision, but when you're looking at trauma and other things, you do have to take into consideration that a whole lot's going to be done at the hospital too. And they did CT him because of posturing. Apparently, that was requested by our hospital. I guess he started posturing right after getting. Compared to, I have at the top, it's from 521. So arrest happened on 511, correct? So the previously severely dilated left ventricle has, and severely depressed left ventricle has normalized. So, 15-year-old heart, I guess. And then all of his function are pretty much normalized with the exception of that baseline rhythm. So this was from our electrophysiologist here, and I like that he wrote that he personally reviewed the EKG, and then I think on here he also said he manually measured the QTC interval just to check and didn't just rely on the interpretation because they were so, they were trying to find something, I think, as to why this happened other than just having that baseline of the PVCs. So then he goes into his differential diagnosis before you can tell he's really trying to think, and I don't know how they find no evidence of Brugada, but that's his job. That's what he does. So, and no evidence of the long QT either. So, you can see basically his whole synopsis there, just saying that they don't know anything other than it's that prior history of the PVCs and runs of VTAC. And right there, he says that this is a very uncommon presentation, especially in the pediatric population, which we know, which is another reason we chose this to run in this review. So they did, I didn't have that in the notes because it was already getting pretty wordy, but they did attempt Verapamil in the PICU. They bolused him and then kept him on a Verapamil drip, but it did not change any of those baseline ectopics. They kept on keeping on. And like Nick said, we visited him. He was the majority of the time in Germany when we were in there. I didn't see any runs, but apparently he's good at that too. So, they started him off of the atenolol because that apparently wasn't doing the trick. Was he arrested? So they started him on this Sotalol, and apparently they're doing well on it. So I was, I immediately questioned, going home to life vest, like, holy cow, can't we do an ICD here? But they want to give him more time, and not even just for the heart test, but I think even just for general anesthesia. They're not overlooking the fact that he had a full blown significant cardiac arrest time. I think reading those, it looks like they're going to try to rather do the ablation. Do I have that in there? Yes, over the ICD, which I don't understand that either. I don't know if Dr. Laffey has any.
If you can find a particular focus, that would be optimal, obviously. But I don't know. Then you're starting to get into
way over, yeah.
Electrophysiology that I'm discussing.
So, same.
I think it's possible. The question is, I have no idea if you can find something.
Yeah. So and then I always love when I see notes from our providers about scars. So I had to add that in there too. That our practitioners do believe in EMS. Our specialties even believe in our program, and obviously, I think this was one that when they saw EMS saved his life, and like, wow, let's do some stars too there. So that came from cardiology to give him a stars plan. So he did go home with a life vest, which he wears 24/7, and Robert educated the whole system on his life vest.
Yeah, radio, and then it's critical. I did the one.
And he's doing very well. So he is completely back to his normal neurological baseline with no physical or cognitive deficit that they can find. And then the life vest is 24 hours, so he's not even supposed to really take it off to bathe. He's supposed to sponge around it. I mean, you're supposed to wash the vest, which even scares me because they're taking it off. Yeah. Well, he has another one, but they take off like the inserts quickly and then put it back on to wash the actual vest part. So, yeah, that's the fact. I can't imagine being mom. So, yeah, it's interesting because it'll automatically fire if he's unresponsive, but it will alarm if he's they set the rate, and I believe it was at 200. It will alarm, and then he has to manually shut it off if he's awake. Otherwise, he's going to get hit with it. So I know mom was sleeping at the bedside because she's like, he doesn't wake up for his alarm. I'm like, oh, he'll hear it because it vibrates too. And they're like, no, I don't trust him. So, and it'll defibrillate. The battery, like they said, at least 5 times, I believe. So, anything else you want to add to this?
I just want to say, Robert, again, fantastic case review. I think the 2 case reviews for the stars and medical really emphasize to the in-house providers and clinicians how strong a lot of our EMS providers are. And I think simply your documentation and your care that you showed. Dr. John Ryder is an old EMT or paramedic before he went down the road of looking at squiggly lines for a living. And so I think just seeing how good that documentation was and how good the care was makes everything else we do in the future for all these patients. Oh yes, EMS is capable of doing it given the right training, the right direction, the right. So strong work.